to put online. We've talked about it that, this is the presentation that will be broken down into the modules, and anyone in the clinic can access certain modules at, any given time or the entire presentation. This is brand new. And I apologize, I have a tendency sometimes to talk a little bit, kind of, before the next slide appears. So please bear with me. I may, repeat myself. I'm still, learning, the compositions of the slides. And since you've been with us for so long, a lot of information probably will be something that you already know. And I'll try to be quick on those slides that, I'm kind of, sure that, this information. But please stop me at any time, ask, any questions, and, let's get started. So, welcome to our program. And the way I'm going to, to go over this presentation probably will be the same way as you will, go through this presentation when you're doing this presentation at the provider side. So I already mentioned that it will be a series of the separate unique modules. So, and we have the table of the content. I'm not going to go over that. You will see, each of this, name every single time we start the new module. So the first one is how to enroll as an EWC primary care provider. So what I want to say here right now, majority of the recruitment actually comes from you. So you're the ones who are recruiting the patient, who are recruiting the providers. So they're not going to contact you. But in the future, when we're going to have regulations in place, uh, we um, we will be mandated to open up our program to any of the providers that would like to participate. So we kept it in mind when we put this presentation together. So when people decided to view what our program is about, these slides will show them how to get enrolled into our program. Right now, it's something that you do, but this is, a portion that kind of, will be more active in the future. So before initiating the enrollment process, a provider should be an active medical provider in good standing, which means they have a valid NPI number. They are eligible to submit claims for payment. They have eligible provider types. We're going to look at that at the next slide. And they have a network of referral providers to provide screening and diagnostic services. So, EWC is not just about breast and cervical cancer services. They have to do, other things. So first of all, they supposed to have clinical comprehensive case management system in place that would include tracking and follow-up system that support quality program and clinical standards. And they should also have designated personnel that will determine eligibility and enroll EWC applicants. We are very unique as the program in that regards, that our determination of eligibility and enrollment is not happening elsewhere, like, via, online portal or at the medical eligibility offices. It's actually happened, at the provider sites. That's why, again, we are so unique. And also another uniqueness of the program is that we're asking for a lot of things. So we have our own EMI records, known as DTEC. So we have to collect and submit program required data into our web-based portal. So providers, have to have designated personnel who will be putting in, all this required data. Nevertheless, the good news is that they will be compensated for that through case management. But, we will address case management later. Second, sorry, sometimes, I have issues advancing the slides, so my apology.
Dr. P, you're on mute.
Okay, thank you so much. So, next slide shows, medical provider types that can enroll into the EWC. So please refer, to this list, whenever you need to. All those numbers are assigned by medical provider eligibility division. So this is not the numbers that we come up with. This is the numbers that are established by the medical. But these are the provider types that can enroll into EWC. Any questions?
Dr. Popova, I noticed that it lists free clinics, and I didn't realize that they could be a Medi-Cal provider type that could enroll.
Yes.
We probably want to learn more about that for our area at some point afterwards.
Oh, well, that's a great question. We can set up a meeting with Lainey because she is the one who provided this list for us, and she's really our expert in terms of the enrollment. So me and Erin, we will take a note of that, and maybe we can set up a meeting with Lainey.
Okay.
So we can discuss this. I'm really grateful for this question. So I'm glad you see something new that may enlarge our provider community.
I think you might have a lot of interest in this.
Great. Well, thank you
Yeah,
for
there's
that.
a lot of free.
Yeah, go ahead.
No, I was just saying that there's a lot of free clinics in our area that would be interested. So I think I'd be happy to join that call as well.
Absolutely. Yes, we will include you. It's interesting, how we learn from each other. And sometimes, we discover something new in spite of that we've been here for quite a long time. I'm happy this slide is here and you can see, the entirety of the provider types. So, Erin, would you mind maybe asking Lainey for her availability so we can set up this meeting? Um, and another option also, maybe, after we have this conversation, depending what we learn from Lainey, we can also invite her to our monthly meeting. Because, if Region 5 have questions, maybe the others should also hear about, provider types. Okay, continuing with the presentation. So providers may be enrolled and participate in the other public health program, for example, Indian Health Program, Family Pact, which is family planning program that provide contraception and screening for sexually transmitted disease and also cervical cancer screening services. Of course, these are the providers that can participate in BCCTP, which is breast and cervical cancer treatment program. And also, you may have come across, of the program called Wise Woman, which is California Well Integrated Screening and Evaluation for women across the nation. This is the program that provides screening for for diabetes and cardiovascular diseases. And the way they work with us is that they choose EWC providers and EWC recipients for participation in their programs. Okay, so now let's talk about our program. So our program really, in a nutshell, it provides breast and cervical cancer screening and diagnostic services to California underserved. And it's important to remember that not only we provide screening, but we also provide diagnostic services. And we will be talking about what diagnostic services means. And besides that, we also do provide a referral to the treatment program because with every single participant in our program, if we identify precancerous or cancerous condition that are on the list of the eligible condition for treatment, all of those patients not just have to be diagnosed and referred but also start the treatment, and we monitor that through Detect. So our mission is that we save lives by preventing and reducing devastating effects of cancer for Californians, with special emphasis on the following: education, patient navigation, evidence-based intervention, screening, diagnosis, and treatment referral. It is important to remember that we are very unique not only what we are asking our providers to do, but also our place in the HCS. Um, if you know there was Department of Healthcare, way back, and then it was divided into the Department of Public Health and Healthcare Services, and public health was taking care of public health initiatives, and they oversee a lot of public health activities, while the HCS is mainly a payer, so it's almost like state insurance for underserved, where we do provide, direct services. And we are unique in terms of we really can belong to either departments. And we used to be with the public health, and the reason we've been transferred in 2012 to Department of Healthcare Services, because we used to have a lot of interagency agreement in terms of paying our claims. So it was somewhat challenging to make sure that our claims adjudication and our payment and our fiscal portion is well taken care of while we were in the Department of Public Health, because again, we have to go through multiple agreements, to do the adjudication of the claims through the medical adjudication system. And the decision was done that we should be the part of the direct payer department, but continue to carry out all of the public you know public health duties. So in that, due to that regard, we are very unique because we continue to do what we were supposed to do for the public health, such as education and patient navigation and evidence-based interventions. So how we are administered. So as you know, we are the part of the benefits division, and what benefits division do is that benefits division establish what we call kind of a floor benefits for all the medical beneficiaries. So if there is a new code, if there is a new service, the doctors and the nurses evaluate whether or not the service should be a part of the covered services, and they want to make sure that not only it's an approved code, but it's also the code that have been, proven to really mitigate effects of the, different diseases, treatment, etc. Oftentimes we have a lot of, pushes from the industry, to cover certain codes. And before we can do that, we really have to make sure that this is not just, a benefit for any kind of, pharmaceutical or medical company. And the benefit is really something that we absolutely, have to put into work, and that analysis is being done by benefits division. So talking about funding, we have state and federal funding. State funding comes from three resources: Breast Cancer Control Act and Proposition 99. Both of this funding actually comes from taxes, for tobacco sales, not just cigarettes, but any kind of tobacco. And of course, this is kind of, revenue source that, of course, is going down because California is very successful in regards to tobacco cessation. So this is not indefinite funding. Every single year our funding goes down from both of these resources. But we also have general fund, which was added to our program, I believe in 2010 or 2011. And the reason why general fund was added is that in 2009 we served so many women that we ran out of funding, and we had to close our doors for any new beneficiaries and for beneficiaries younger than age 50. It was almost like a huge scandal that it happened, although we warned about it, in advance, and the management knew about it. But the problem is that it's coincided also with the new, at that time, new USPSTF recommendation that women should only be screened starting age 50. So people put together these two things and thought that, we just following USPSTF new guidelines, but that was not the reason. But because of the attention of the public to the new guidelines, because, a lot of people really protested, initiation of the screening at age 50. A lot of, doctors, medical community advocates, and patients community advocated for starting screening at age 40. And the fact that we were closing the door and two facts coinciding together brought us a huge attention, and we had three different audits of our program. And as the result, they didn't find anything bad, with the only thing that we still don't have regulations in place, which we still don't have, and hopefully they will, come into action, this year. Um, but the good thing is that we were the only program that got augmentation by general fund, while all the other programs have been slashed because that was the time of a huge financial crisis in California, where we all have been furloughed in all the different state departments. But we were the only program that got general fund, and since then, we have to justify and kind of foresee our future expenses, so we can ask for sufficient amount of money coming from general fund. So I apologize that, kind of spent some time, describing that, but I think it is really important for everyone to understand, how important for us, to do fiscal analysis, foresee different circumstances, because, funding of your contracts, funding of our program in general depends on that. And then we have federal funding, which comes from National Breast and Cervical Cancer Early Detection Program. Super important funding. It's not the largest. Sorry, I don't remember percentage wise, how much comes, but we model our program after NBC CDP. So whatever requirements they have, we have these requirements for the entire program. So although we kind of divide the funding, but the way the program administered is it's administered as NBC CDP program. So we have the same requirements for our providers, regardless whether they belong to federal subset or state subset, and they usually don't know which subset they are. So NPCCDP is managed by CDC. So oftentimes when we talking about federal funding, we may say NBCCDP or we may say CDC. We kind of use this interchangeably. So NBCCDP served more than 4.3 million over the last 20 years. And every state has the unique program, and usually unique name and different eligibility criteria. If you're ever interested, you can go to the link below and you can find out more about the programs, but you have to understand that some programs do have state funding, some only have federal funding, and the programs vary differently depending on the size of the state. And, in some of the states, especially in smaller ones, they contract with the screening entities directly. They may only have a few clinics in their program, and they only serve maybe a few thousand women, while we are probably one of the largest. CDC never really disclosed which program is the largest, but it's probably either us or Texas. Okay, this is a little bit of a statistic so you can understand, where we at. So before COVID, in 2019, this is just a sample, but again, I think it's important to understand, how we've been doing, in the recent years. Approximately 991 individuals were diagnosed with breast cancer. 127 of them had not invasive cancer, what we call in situ breast cancer, and 849 had invasive cancer. 39 individuals were diagnosed with invasive cervical cancer. Just based on this number, you can, understand that, cervical cancer is not the most common cancer, but most importantly, it's very preventable cancer with the vaccination efforts and regular screening. So there is no surprise that the numbers are maybe small. Nevertheless, our goal is truly to eradicate this disease because, with the vaccination efforts and regular screening, at some point in time, we really should have, zero individuals with invasive cancer. So in 2021, our caseload was 168,763, and that was both underinsured and uninsured individuals that receive our services. Any questions? So I hear none.
No,
Go ahead.
no questions.
No questions. Okay. Do I speak quickly or is it okay? Because I know I have a tendency to speak fast. Okay, let's go ahead. So you probably all knew about our structure. So we divide, California into 10 regions. This division was done quite a long time ago, and um, there could be questions to that because we have some territories that are really small but have many providers, such as the census. And then we have, huge areas of frontier, and kind of, rural areas where we don't have a lot of providers, but also don't have maybe, a lot of recipients either, at least density of the population. And, sometimes, some of the regions take over some of the counties. So this is, the map, how it looks now. We're not planning to change it, but things may change slightly. So the reason we work this way is that we would like to address the needs of the population really at the local level. And we also want to make sure that our health educators, working very closely with clinical coordinators and guide women into the screening, and that our provider network really, suffices that need. And we have providers, everywhere where the classes are being done, where we recruit our women, into screening. So this is again the map with the name, for all the 10 regions and how we call them. And further, these are the slides with the links, to each contractor. So I'm gonna go quickly through that, and you can look at that, when we're going to distribute this presentation. And as I said, we're just waiting for this presentation to be formatted because we had some issues with formatting. So once it's formatted and it looks beautiful, you all will receive a copy of that. So in terms of health educators, Brianda, you probably know it like nobody else, as well as June, but let's just summarize it. So health educators, they provide community outreach and education about the importance of early detection. They recruit EWC eligible patients into the program. They collaborate with the community leaders to offer small group health education classes. Of course, very important thing is that we also utilize network of community health workers to recruit individuals into the classes, and they translate and establish collaborators. Also important is that we provide navigation services for those individuals who are interested to work with us. And during the classes or during the recruitment of women, we ask if they would like to be, guided by our health educators, who making sure that women at the end of this navigation do go to the provider and do receive screening services. So clinical coordinators. Um, what is required from clinical coordinators? First of all, they are registered nurses, so they have clinical background, and their major job is to maintain provider network through training and support and clinical technical assistance for enrolled primary care provider and referral providers. They recruit PCP based on the regional needs, and as you all know, we're doing the RCNAP every year to make sure that our health educators activities are align and corresponds with the activities that clinical coordinators do in terms of recruitment and provider network maintenance. They also ensure provision of appropriate and timely breast cervical cancer screening services. And we're going to talk about it. You probably all heard about CPPIs. We showed you the table yesterday, and we're going to talk about what the CPPI means and what quality criteria we have established. But that last bullet point really speaks, how we can ensure that we meet CPPIs. So regional, structure, again, clinical coordinators offer patient navigation, and they offer it to EWC enrolled individuals. For those who are not eligible for EWC, um, they may also come to our program, and we need to make sure that all people who comes to our program, we send them to the appropriate resources. We also have individuals who may be diagnosed elsewhere, and we want to guide them into the BCCTP because they are eligible for BCCTP. But there is a little bit of a caveat, and we will talk about it when we will be talking about BCCTP. They also partner with enrolled providers to implement evidence-based interventions. So how patients usually, learn about us? You're probably all familiar with online provider locator and also 800 number. So through all of, both of the services, telephone and online services, patients can search by mileage from where they reside. They can also, look up whether or not providers speak certain language or have female providers on staff, whether or not they have evening hours or maybe, weekend hours. So, and also one of the things that I mentioned, I was yesterday during our meeting, is that it's extremely important to keep provider information accurate. So when people look at our resources and try to find the provider that our information is matches what is really happening in the region, and we're not sending them to the wrong addresses. I already spoke in regards to the role of health educators, how important for us to have health educators in the region who recruit women for the program, and of course word of mouth and internet, and also providers do enrich. So if women come for any of the breast and cervical or diagnostic, screening services, or even if they come for different reasons, providers can always, check whether or not the woman is eligible and enroll her into EWC. Any questions about the previous module? Okay, if not, I'm going to talk about provider recruitment and responsibilities. So as we mentioned before, EWC PCP should be a medical provider in good standing and eligible to submit claims, and have their own NPI enrolled with medical um, provider, enrollment division, and then they also must be enrolled with EWC separately. They should accept medical rates as payment in full, so there's no balance billing for patients, and they should also have internet access and capacity, to enter the data and enroll patients through the tech. Um, and that they also have personnel to enroll EWC applicants and submit clinical data. So EWC primary care provider determine applicants' eligibility. They enroll qualifying EWC recipients. They also recertify existing EWC recipients. So, you probably, remember that our eligibility is only valid for 1 year, and patients have to be recertified. And it's extremely important that if somebody is going through, like diagnostic workup, providers have to make sure that their eligibility does not expire. And we will talk about it, but we cannot enroll patients before eligibility expires. So there should always be plan in place. If eligibility expires, when patients should come back to PCP to get recertified. Other duties is that they deliver EWC program services in accordance with our clinical quality standards, in other words, CPPIs, and they agree to disclose any non-covered services to the patient and receive their written authorization before services provided. I'm going to give you an example from yesterday discussion. If you remember, Marilyn brought up the fact that one of the large radiology providers is purchasing smaller radiology centers, and they kind of forcing patients into A&I, reading of their mammograms, and they collect additional $40. So if they're gonna do that, if they're gonna recommend any of these services, and patients agree, there should be a written agreement from the patient where the patient states that they understand that this is not EWC covered services and that they agree to pay out of the pocket. Also, primary care providers supposed to provide and coordinate all screening and diagnostic services, which means that they have a good referral network of medical providers for screening, diagnostic, and treatment services, and they have clinical system in place that include tracking. And I know we talk about it all the time, but tracking is really important, and we do find, clinics that don't have a good tracking system. They don't have even system in place where they systematically, try to reach out to the patients that don't show up for the appointment, don't come back for their diagnostic services. So tracking is super important. Um, Also, primary care providers, they make referral to treatment. We've talked about it already. They collect and report recipient outcome data to EWC, and they're supposed to do it on every single patient that they screen or that to whom they provide diagnostic services. Another important point is that CDC or NBC CDP required to make assessment of the tobacco use, and this is the federal regulations. We collect this information when patients are being enrolled, so front office staff should always pay attention. If applicants, answer the question about tobacco use positively, so they have to alert the provider about it so the provider can talk about tobacco cessation and also refer patient to cessation resources. And we listed two of the major resources such as KICIT, which is formerly No Butts, and California Tobacco Control Program. Another important thing is that there is a system in place to provide notification of the recipients about the test results. Um, so we have timeliness standards for patients' notification. So all the negative results should be conveyed to the recipients within 30 calendar days. For the abnormal results, they have, they have 2 weeks, which is 14 calendar days. And the cancer diagnosis, should be, patients should be informed about it right away, but no longer than 7 calendar days. And it's kind of, unwritten rule that, you know, conveying cancer diagnosis should be done face to face. Of course, sometimes, it's being done over the phone and, the worst case scenario over some sort of, um, messaging, through the portal, but truly, um, this kind of notification has much better outcomes, compliance, and understanding through face to face contact with the provider. So also EWC primary care providers, they refer recipients for diagnostic evaluation and treatment as needed. Referral diagnostic evaluation should also be done within 14 calendar days from the receipt of abnormal results. And although we're not calling it CPPI right here, but the final diagnosis should be reached within 60 days from abnormal results. That's one of our quality standards or CPPI standard. Referral for treatment following the diagnosis of breast and cervical cancer or other high-grade cervical diagnosis, which we call cervical precancer, also must be made within 7 calendar days, and the same timeliness for initiation of treatment. It's also 60 days from the day of the diagnosis. So the time should not elapse more than 60 days, but our hope it's the treatment actually starts right away. Primary care provider should always, inform clinical coordinators if there is a change in ownership or legal address, change of the physical address or phone numbers, or change, of any contact information, for clinic administration, medical director, or EWC contact person. So let's talk a little bit about referral providers. So they have the same standards. They also must be medical provider in good standing or with enrolled MPI. They should be eligible to submit claims, but they are not required to enroll into EWEC. So pretty much any medical provider that can do breast and cervical cancer screening or diagnostic services can be a referral provider. Usually, when we're talking about referral providers, most of the time, these are imaging centers, surgeons, labs. And when we're talking labs, we, mainly talking about pathology labs. So referral services do not need to have any pre-authorization. Referral providers should always check on recipient eligibility. I just spoke about it. So their card should be with valid dates because if the service is provided, for the patient whose EWC eligibility has expired, those claims will not be paid. So it's the responsibility for the referral providers to make sure that they, um, you know, that they provide services to the valid recipient. So reports should always be sent back to the PCP. They can only render covered services. Otherwise, again, they would need to get the disclosure from the patient for non-covered services. And the report should be sent to PCP in timely manner and include screening and diagnostic results, recommendations, and treatment plan. They should submit the claims with our 14-character recipient ID, and I just sent you an email how this recipient ID is created. We finally uncovered something that we really never addressed before. So it seems that the first numbers for the recipient ID comes from the um, from the provider residence or provider location. So and also a referral provider should accept medical rates in full. Any questions about the module of provider enrollment? Okay, going along. So let's talk about online resources for EWC providers. So you probably saw this page. You know, for Brianda and your June, you probably know that all of the publication has recently changed their online addresses, and we want to make sure that our links are valid, and that people know how to get to the resources. So as a screenshot, you see one of our main pages where we have links to our manuals and to the notice of privacy practices and recipient application and also provider data request forms. So two major manuals that we have is F Woman, and every woman is pretty much the manual that speaks about eligibility, enrollment criteria, policy and standards, approved diagnosis and procedural codes, and billing instructions. And the next manual is step by step, and this is the guide how to enroll and how to submit data. So it's a data manual. Um, I just wanted to ask a question. So tell me, are you using these, manuals all the time? Are you familiar with them? Did you have a chance to review both of them? Caitlin, Brianda, do you like, what is your
Yeah, I've
experience?
been through them. I've read through it. Me and Sharon went through it, and then yeah, I think we do use it. So like, if any of the PCPs have any questions, or especially with DTech, we just kind of send them a screenshot of what it says in the manual and tell them like, oh, if you have any questions, make sure you go on the online link because that's going to be the most updated.
Okay, so you're familiar with that, you're comfortable, you don't have any questions about, neither of these manuals, right?
Yeah, I'm pretty comfortable with them.
Excellent.
Oops.
Okay. So we already showed this screenshot before, but this is our website that I really hope we will reorganize, soon because we need to make it um, more user friendly and we have to put more resources. So I really hope that it can be revamped in the near future. But one of the major things there is that it has the provider locator, it has educational materials that were developed by EWC. It also has income criteria so patients can quickly look at the table for the income criteria, and it also has link to our guides, forms, and other breast and cervical cancer resources. So, besides our own pages, Medi-Cal also provides some of the trainings that are not done by us, but they are done usually by the field workers or medical fiscal intermediary. So, Medi-Cal has catalog of all the courses, and this catalog is not about AWC. It's really about all the courses for different programs within the HCS. But if you look at this, catalog, when you go to this, page for the medical learning portal, you will be able to find the training series. I'm going to show you right here. And this training series would be about AWC. Um, so, and let me just tell you that when you click on that, you will be able to see a calendar, when those trainings are available online. So, in terms of provider resources that are done by the field representatives, from the medical, so they can provide one-on-one assistance throughout California. These representatives are, available and they can visit providers in the office or virtually, and it would be at no cost to the providers. You can schedule those meetings with them through the TSC, which is the Telephone Service Center. The number is listed, and you just tell them that I'd like to contact the regional representatives, and you will be all set. So if there is no questions, let's talk about applicant eligibility. And you probably know this portion really well. So I'm gonna go through that quickly. Stop me at any time if you have any questions. So age is super important, even if you know that. So remember that for cervical cancer screening and diagnostic services, we screen people who are older than 21, and we don't have upper age limit. And the reason for that is that, infrequently we have people who did not have satisfactory screening status in the last 10 years. And that's important that we screen these women without any kind of barriers. So, for example, medical has the rule that everyone who is over age 65 and they require screening, they need to get pre-authorization for HPV and pap test. We felt that it was a huge barrier, and I fought against that for our women. Therefore, we don't have any pre-authorization, and our women can continue to have screening after age 65. Breast cancer screening services. So, for people who are average risk, the initiation of the screening starts at age 40. Nevertheless, there is no age limit for high risk individuals. They can start screening at any given time. Again, we don't have age limit for that. And for diagnostic cancer services, um, these services are available to any symptomatic individuals of any age, and we will talk about it more specifically, when we will be talking about, screening guidelines and our covered services. So residency. So there should be, a physical California address. Even if, people homeless, they should let us know, what is the address where they can be contacted and where they can receive mail. Um, we do serve women in frontier areas from other states, but again, they have to indicate California address if they have one. Income. This is kind of, supposed to be straightforward. It's at below the 140% level, and this is self-reported, and we don't require any proof. In regards to the insurance, so people should not have any private or public health insurance, or if they do have insurance, they're not able to afford deductibles, co-payment, and share of cost. What is important to remember, and I'll talk about it, later, that again, we're not asking for any specific information. What is their deductibles or co-pays? We don't judge based on the fact that your payment is $30 versus maybe 300 out of pocket. If people cannot afford it, they cannot afford it. So in regards to the age, so I kind of went over that, so I apologize. I told you I have a tendency sometimes, to go ahead of slides. So let's just look at the repeat of that. I hope no questions here. So let's talk about symptomatic individuals. So symptoms may include and not limited to palpable mass or lump in the breast or under the armpit, change in size or shape of the breast, changes in skin texture or the color, such as dimpling, puckering, redness, scaliness, or thickening, either of the breast skin or nipple, nipple retraction or inversion, axillary lymphadenopathy or swelling, nipple discharge, and breast pain. And of course, um, all of these symptoms are concerning for breast, but again, doesn't mean that having a symptoms equals breast cancer diagnosis. This is just symptoms that are concerning of a cancer. So we've talked about residency. So this is the list of the eligibility criteria. And it's being updated every year and published on the 1st of April. So this is the table that will be valid just in a couple of days. Again, this is self-reported. We're not asking for any documentation, but it's important to remember that our eligibility criteria are the same for BCCTP enrollment. And because BCCTP, it's really a program where they have eligibility workers. And the major duty for those workers is to verify all the eligibility information. So they would get the information on the income and they will verify the income before patients are enrolled. So it's important to know that although we don't ask for that, patients have to be prepared that they would need to show this documentation if they would be in the need for BCCTP. So in terms of the applicants who should be counted, an applicant and members of the applicant family and household. So what is the gross input? An applicant must include the total amount of money that you or your or people in the family household receives before taxes and other deductions apply. And household include the total number of person that you consider above. So we already talked about insurance eligibility and guidelines. So people who are uninsured, it's kind of clear cut. Underinsured, people may have limited scope medical, such as pregnancy or emergency. They may have, usual private insurance with some benefit restrictions that exclude, some of the services that are available through EWC. They can belong to medical with unmet share of cost or private insurance with co-payment and deductibles. One of the important caveat is to remember that usually any screening services, that is recommendation A and B from USPSTF, this is this is United States Preventative Task Force, and we will have an additional training regarding screening guidelines. That's not part of this particular training. It will be more about, clinical screening guidelines training. And we will talk about those recommendations, A and B. But A and B recommendation, which is screening recommendation, means that all the insurances should cover that. So ultimately, majority of the insurance cover those services. But when it comes to diagnostic services, that's when people would need to pay out of pocket if they have any out of pocket um, expenses. And that's where EWC is extremely helpful. The only problem is that we are a pay of the last resort, which means that, you know, we really shouldn't be paying for the entire services, but unfortunately, there is no way to reimburse to the patients directly, their share of cost, which means like, if they have, let's say, $300 out of pocket, we cannot reimburse them directly. At this moment, we're still covering, the entire procedure, and that may lead oftentimes to changing medical homes. So they receive services at one provider and then they have to switch to EWC and go to different providers. That's one of the issues that extremely difficult to resolve, but at least patients are not left, behind, and they can continue their, diagnostic follow-up until they reach final diagnosis. And as I said, again, it's self-reported. We're not checking what is the cost, or what is their out of pocket. We're not judging them on the amount, and we take care of anyone who meets all of our other eligibility criteria. So frequently asked questions, does ACA or Covered California affect eligibility? So many individuals have comprehensive coverage through either Covered California or Medi-Cal expansion. And as we said earlier, if they're unable to afford any of the payments, they can get the diagnostic services through us. Does immigration status affect eligibility? Absolutely not. Immigration status is not part of our eligibility criteria, and we don't look at that. We serve anybody, whether these people are citizens, have satisfactory immigration status, or have unsatisfactory immigration status. So, do we cover transgender individuals? Absolutely, yes. And let's talk about it a little bit, and please stop me, if you need more clarification. So we cover breast cancer screening and diagnostic services for cisgender women, meaning women who were born as women who consider themselves women. Transgender women. Transgender women are those who were born male and they consider themselves woman. So we cover the services if these people have taken hormones. What it means. So if somebody was born as a male, they have breast tissue. Males do get breast cancer, but extremely rarely. That's why we never do screening for males, because that's not the disease that they have. It's really very handful of cases in the United States, every year. Nevertheless, once people start taking female hormones, their risk for developing breast cancer increases. So that means that transgender women who taking hormones are eligible for our services. Now, what's about transgender men? Those who were born female but transition to being a man. Do we screen them? Yes, if they did not have bilateral mastectomy. What it means, bilateral mastectomy is an operation where the entire breast tissue, in the area of the breast, sometimes, in the, armpit, is completely removed. So basically, none of the, breast tissue has been left. So if transgender men didn't go and didn't get this operation and they still have breast, they should be screened. Also, some people, have top surgery where they just have, partial removal, of the breast. Again, with these people, part of the breast can still remain and they still would be eligible for the services. Any questions here about transgender and breast cancer? Okay, so let's talk about cervical cancer screening and diagnostic services. They are available for any individual that has a cervix, and we don't really define, cisgender women or, transgender men. If a person have a cervix, they need to be screened. And again, our diagnostic services are available for any individuals, regardless they are, their gender, because if they, experience any symptoms suggestive of the breast cancer, they are eligible for diagnostic services. Okay, we already talked a little bit about what BCCTP does, and the question is, can patients be served by both Family Pact and EWC? Yes, they are, but only one program can bill for each services, so programs cannot be double dipped. Cervical cancer screening and diagnostic services should be billed to Family Pact first because EWC is a payer of the last resort. Only breast cancer screening and diagnostic services should be billed to EWC because these services are not provided by Family Pact. So our difference between us and Family Pact in regards to the cancer screening, they do provide cervical cancer screening and some of the diagnostic slash treatment services. We're not going to go into details at this moment, but later I will tell you what diagnostic slash treatment services available through Family Pack, but they stopped providing breast cancer screening services probably around 10 years ago. Therefore, any patients that are being seen at Family Pack should be referred to us for breast cancer service. So this is, kind of a comparison table between EWC and Family Pack. So we covered that the breast cancer is only covered by us, pap test covered by both of the program, HPV and co-test covered by both of the program, and diagnostic services. We cover diagnostic services, but we refer to BCCTP for any of the excisional procedures, and Family Pact do cover excisional procedures such as LIP. Any questions about previous module? Okay. So let's talk about EWC recipient enrollment. So first of all, the first step would be, when patients come to the provider's office, that first of all, we refer them to more comprehensive coverage. We give them information about covered California and Medi-Cal information. And this is so important because it turned out that some of our recipients that we start covering actually is eligible for Medi-Cal. And we especially see so many cases when people, come to BCCTP because for BCCTP, one of the requirements for enrollment is that these people are denied for the Medi-Cal. So they not accept any application unless these people apply for Medi-Cal and have been denied. And what we found out over a few years when this provision was in place is that people do get Medi-Cal all the time. And it's extremely important to make sure that before we're serving them, people have been evaluated for Medi-Cal or may choose covered California. The second thing that should be given to the applicant, it should be notice of the privacy practices. These are the links. So when you click on that, you will get to the information about covered California or notice of privacy practices. We usually recommend to make kind of a laminate of the privacy practices notice and give it to read to a patient. If patient wants to have a printed copy, provider can do it, but it's just we know that most of the time patients just throw a lot of paperwork into the garbage, so you don't need necessarily to give this to every patient. But this is policy within the clinic, is just the suggestions, and they can distribute notice of privacy practices as they see fit. And the next thing, but the vital and critical step is EWC recipient enrollment application. So without that, you cannot enroll anyone. So I already mentioned that Affordable Care Act, or comprehensive healthcare coverage is always should be the first step. So we do have pamphlets. Oops, excuse me, sorry. So we do have pamphlets, free and low cost insurance in covered California. Those pamphlets are available on our website under education materials, and you can click, on this presentation, you will be able to get there. And then, this distribute, I mean, this information should be distributed at least annually, every single time we either enroll patients or recertify, but they also can be distributed at any other time when patients comes to the office. So this is how notice of the privacy practices look like, and it's also available online. So next, enrollment steps. So screen recipient application for eligibility. Patient receives and completes enrollment form. It has multiple pages, and some of the pages are instructions for patient. Some pages are pages that applicants have to fill out. And then we also have pages for staff, and we call them for EWC primary care provider for internal use. So this is sort of a checklist where the enrolling provider want to make sure that every single questions have been answered and that those answers fall within our eligibility. So only after making sure that you review the entire application and provider certifies that they verified, all the, points in the provider application, only then we enroll patients through the tech. Providers have to print recipient ID card and provide it to a patient. They also have to print online recipient summary. We also call it enrollment summary, and it should be placed in patient file. And of course, right now we have a lot of EMRs, so it can be, scanned, saved as an electronic version. But this enrollment summary is the proof that patient was enrolled on a certain date, and recipient should be provided with the recipient identification card. So what other documents that go into the medical records? So all the pages that filled out and signed by an applicant or a person acting on the behalf. So we have sort of, paper or electronic proof that the patient applied for our program. Pages for internal use that are filled out and signed by PCP staff should also go into the medical records. Online recipient information form and copy of the recipient ID. So recertification period, as I mentioned, should happen every year, so each 365 days. Certification must be checked each time patient is seen, whether by primary care or by referral provider. If certification expired, recertify the patient if she or he eligible. If patient changes to a new PCP, they need to be recertified with the NPI of the new provider. So that's important caveat, and you're probably well aware of that you have to register and get recertified with the new provider. And every single time somebody, comes to the office before the enrollment, we have to verify that this person have not been previously enrolled. So we're not duplicating the records for the same recipient. When a new well, I just said that, sorry. Let me. So this is how the recipient enrollment application looks. It is available on the medical website in multiple languages, and it should be completed at initial enrollment and recertification. Um, so applicants, as I said, complete, all the pages that looks like this, where we have, space to fill it out, and this should be retained in the medical records. This is how the checklist looks like. Again, we've talked about it. And EWC provider staff must complete and sign those pages 10 through 12 on the recipient application form. Regarding the signature, we recently changed our policy. We used to have remote enrollment via telephone capabilities during COVID, and we felt that we should keep this capability now, even after COVID, because it removes a lot of barriers, especially for women that live in rural areas or frontier areas. And in order for them, for example, to get a mammogram, they really don't need to see the primary care provider. We no longer require a clinical breast exam, and they can directly go to the radiology provider, but they should still have a primary care provider who can consult them, how frequently the patient needs to be screened. The provider, can analyze the results of the mammogram, explain things, but it doesn't necessarily require, patient's visit. So if patients only need recertification or enrollment in order to get to a mammogram, for example, it's really vital that they can do it, over the phone. And we make sure with our Office of Legal Affairs that we do accept verbal or telephonic signature. We have, we don't have this form yet online, but our recipient application form um, has been changed, and it will be online, hopefully within months or so, where we describe in details what needs to be done, and we have all the appropriate instructions. But in a nutshell, we ask that applicants verbally acknowledge the consent, and then when PCP staff takes this verbal consent, they documented that it was verbal and put their name, their position in the clinic, and they date it. Of course, handwritten signature, or in other words, wet ink, still acceptable. And the other thing that has been instituted for some time is electronic signature. So electronic signature is acceptable, and many providers have transferred our application into the electronic system. Unfortunately, our application is a little bit behind, and one of the reasons we're updating this application so that our signature on the form can be done electronically. So the form that I'm talking about that will be released soon will have ability for what we call DocuSign or electronic signature. So it can be wet ink, or it can be electronic. But in general, what electronic signature means? So it can be handwritten signature that is put into the electronic signature pad, as we do right now in probably any stores. Handwritten signature that or comment on the display, such as the stylus device that we use when the document is displayed on a touch screen. Digitalized image of the handwriting signature that is attached to the electronic record. It may be type name, it can be unique identifier such as password or code, electronic recorded sound such as the voice recording. It can be, just a click of a mouse that says I agree, or any other digital signature as defined in section 16.5. Let me make sure that you understand what I just mentioned to you. This is electronic signature submission that is allowed by our department. We did not develop these bullet points. This is what is accepted as electronic signature transmitted for the entire department. And that's the language that was given to us. But as you can see, there's a different form how the electronic signature can be captured. And that's the list for your reference. So in order to get patient enrollment, it should be an online enrollment. You have to log into Detect Online. In order to do that, you have to go through the medical website called homepage, and log in to a provider portal. You enter your email address and you register a password. And once you log in, you're able to navigate to detect. So now I'm going to quickly show you. These are all the steps that we have in order to get patients enrolled. Why I'm going through that, not spending any time. So as you heard yesterday, detect will will move, and all those screenshots will be modified. So they will be, in a nutshell, the same, but the way they're gonna look, will be different. So all those screenshots will also be, updated in the step-by-step user guide, and that's why, I'm gonna, you know, for now skip those slides because later when we have the new slides we're going to go over them, and you will be able to provide these orientations to your providers. At the end you will have the screen with the successful enrollment. Probably is going to look different anyway, but on the screen you will see the recipient ID and certification period. As the result, the recipient ID card will be produced that will look like that, and that's the card that should be given to a patient. If patient is enrolled via telephone modalities, the card should be sent to the patient, or patient should pick it up, whatever is more convenient, but they should at least have their ID number to be able to be seen by a referral provider. So certification period. Recipients cannot be re-enrolled before their certification ends. I mentioned that before. If certification expires within 13 days, you should have a plan for a patient. So go through the application process, give all the brochures and sign application, verify eligibility, create a reminder for the patient when they should come back, to get the new card, and then recertify individual only when detect shows expired, and make sure that recipient gets the ID card in return for that, or the card is mailed to a patient. In rare cases of detect outage, although it's rare, but we recently did have an outage, and we had an overwhelming number of the providers reporting that to clinical coordinators and directly to us. So usually if that happens, we have what we call 30-day eligibility grace period. So the data into detect can be entered, at any time later, within 30 days. You can still see patients on the same date, and if you want to, hold off, on the application or data enrollment, you can do that. But we also have a paper copy which is listed on our AWC resource page with all the forms. All the data for the patient can also be entered, in the paper version. That's really rarely required. Nevertheless, you can use this form also as a kind of a duplicate, to know what fields we have in DTEC. Any questions here regarding, DTEC system outage and what to instruct and what to tell the providers?
I have a question about this, Dr. Popova. So
Okay.
if there's a grace period, but these patients are going to have an upcoming procedure, say a diagnostic mammogram in the next, I guess, in those 30 days, and they need to present their EWC card, but they can't have it just yet. What should they do? Or will that just get sent afterwards after the application's entered?
Yes, if it's within 30 days eligibility period, you just get the data in as soon as possible. But
Okay.
as long as this procedure will be within this 30 days grace period, providers will be able to bill for that. So the eligibility period for these people will be 30 days. So even if the let's say enrollment is done, let's say on the 1st of November, the services could have been done starting October 1st.
Okay.
Again, that doesn't happen very quickly, I mean, very frequently, but we did have, I believe half a day of an outage. And whenever that happen and you are alerted, please, alert us because we will put all our efforts into making sure the application, I mean the application platform is up. But 30 days period was done specifically in mind that glitches and electronic capability can be down. So that's the reason for that. And also some other caveats is when people are being seen by mobile mammography and there is no provider to enroll patients, but they can do it at a later time. I hope that makes sense. But that's our kind of, safety cushion, and it has been utilized, and this works well.
Thank you.
Okay, so we have covered services, slide 86. And I actually want to stop here because I don't think we have enough time to even go through this module. Um, but we've done more than a half. So